Okay, welcome. My name's Chris Smith. I'm a radiographer based just outside Belfast in Northern Ireland, and today we're going to be running over anterior posterior knee imaging or AP knee imaging in terms of a radiographer's perspective. So we'll run over some learning outcomes for the session. So by the end of it, you will be able to state common clinical indications that can justify performing knee imaging, describe the correct patient positioning, centering point, and collimation for an AP knee radiograph, identify the key anatomical structures demonstrated on a correctly performed AP knee radiograph, and evaluate an AP knee radiograph for rotation and overall image quality. So, um, before we move on kind of to the radiograph itself, it's very important to kind of understand what we can actually justify knee imaging for. So there are various clinical queries that will come through the imaging department that you can accept and justify knee imaging for. So if you want to have a wee think about some there before I put up the list. So I have a list of 9 here, and 10 is obviously other relevant queries, but 1 to 9 we have fall onto knee, ongoing pain, other trauma, query suspected fracture, very common referral, suspected knee dislocation. However, it's important to note that likely you're going to require a skyline and a lateral as well as this. Post reduction check, so this is if someone's patella has been dislocated and they want to check the overall position of it after relocation. Ongoing pain, a lot of GP patients will present with a history of weeks, months, years of pain, and they're requiring osteoarthritic changes. Reduced range of movement, also abbreviated to ROM. Kind of wondering what's the cause of that. Do they have known OA or osteoarthritis, and they're seeing how this has progressed. Pre-surgical planning and post-surgical checks, maybe before a knee replacement or after a knee replacement. And if someone has a known cancer diagnosis elsewhere, they're maybe got femoral pain and they're maybe wanting to rule out a MET in the distal aspect, so a knee radiograph would justify this as well. And of course, as I said earlier, any other relevant clinical query. So what type of projections do we do then for knee imaging? So today we're only going to be covering an AP knee or an anterior posterior knee projection, but there's various other types we can do, such as a lateral, skyline, patella image. We've got Rosenberg's as well. So a variety of different types of knee imaging, but today we're only going to be covering the AP knee. So we can do the AP knee projection either supine or erect, which is also known as weight bearing. Majority of the time for a supine image, these are going to be your patients that have presented in the instance of trauma and they're not going to want to weight bear, whereas the weight bearing ones can be beneficial for patients that they're carrying osteoarthritis and they want to see the knee in its true anatomical position when we are walking or weight bearing. For the supine imaging, so the patient will lie supine on the imaging table. The affected leg will be extended. The image detector, also known as the ID, is placed under the affected knee. The condyles of the femur will be positioned equidistant from the image detector so that the patella is positioned midway between the femoral condyles, and this usually will be you internally rotating the leg slightly. So if we transfer that then to a weight bearing or an erect image, the patient will stand erect against the image detector. You can see it's placed behind his right knee there in this image shown. The affected leg is fully extended, and once again the exact same as a supine image. The condyles of the femur will be positioned equidistant from the image detector, and the patella centralized between the femoral condyles. And once again, that's achieved by usually slightly internally rotating the leg. So in terms of center points, they're vital for radiographer to understand and know, because it ensures that we're over the correct area of interest and that our radiation source is only over the required area. So I've demonstrated here are two center points for both the supine and the weight bearing or erect projection. So our supine imaging will involve, and I've made this bold, a vertical center ray, and it is directed perpendicular to the image detector, so it's hitting the image detector at 90 degrees, and it's 2.5 centimeters distal to the apex of the patella of the affected knee, so just the tip really of the patella, that you would be easily able to palpate on a lot of patients, the bottom part of the patella. And if we transfer that then to our weight bearing one, it's obvious that now it's going to be a horizontal center ray, and I've labelled and shown a direction there on the image. And once again, it's the exact same. It'll be hitting the image detector perpendicular or at 90 degrees, and it's on the same location, 2.5 centimeters distal to the apex of the patella of the affected knee. So on this slide then we are going to be chatting about the collimation, or the area to be included. So for AP knee imaging, we need the distal third of the femur, the proximal third of the tib and fib, or the tibia and fibula, and then the bilateral soft tissue margins, to ensure that we cover all the required anatomical area. So what anatomical area do we need to kind of know as radiographers, or be able to identify on knee imaging? And this is the purpose of this slide. So we've labelled it 1 to 11, and you can kind of pause the video if you want and kind of run through them all, but very, very important to understand and be able to identify the femoral condyles, medial and lateral ones, the patella, the fibular head, and obviously identify overall the actual femur bones, femur bone, tibial bone and fibula bone. So we have then, as radiographers, to be able to understand if our AP is a true AP. So we assess the projection of the image. So does it look like a true AP knee image should? So to be able to assess this, we are checking, is the patella centralized between the medial and lateral femoral condyles? So you can see here the patella, and this is medial, this is lateral, and we can identify what's lateral by looking at the fibula head. So the fibula and the fibular head will sit in the lateral aspect of the knee. So the patella is therefore sitting away from the lateral aspect, so it is appearing medial. However, it should appear centralized, and it should be between the lateral and medial femoral condyles. The condyles should also appear symmetrical, so we're looking for the lateral condyle and the medial condyle. Do they look the same? We should have a clear femoral tibial joint space, and the head of fibula should just slightly superimpose the tibia, which it is here. So in terms of this, it's not bad, but we could improve it by bringing that patella laterally, and we're going to achieve that by externally rotating the leg. So other requirements then, when we're undertaking an AP knee radiograph, so an anatomical marker should be present. So this does have an anatomical marker present, but it definitely has been post-processed. There should be good bony trabecular pattern, so the image should not appear overexposed, so we should be able to overexposed or underexposed, so we should be able to identify the patella behind the femoral condyles there, and then we should have no artifacts present on the image whatsoever. So as part of a radiographer's job, we should be able to critique an image and know when to repeat the image. So we know what areas should be included on a AP knee radiograph. So it's important to be able to identify when the correct area and the correct projection has not been achieved. So we can identify the patella here. It's sitting very lateral. So I've labelled medial and proximal. So if you imagine laterals here, distals here, we know this is lateral because the fibular head is on the lateral aspect of the body, and we can see it on the lateral aspect of this image then. So the patella is sitting laterally. We should be able to identify at this point if we've got the proximal third of the tib and fib and the distal third of the femur. It's most obviously not visualized on this image. We also do not have our medial soft tissue borders here as well. So if we know our centering point should be 2.5 centimeters distal to the apex of patella. So if we look at this image and draw up the center of it, we can tell that it does not appear to be correct. We can see that it is sitting too laterally here. We need to bring it medial. It also appears too distal, so we want to maybe bring that up more proximally to around this point here. So we've assessed our centering point, we've assessed what area should be on it, which this image does not have on. Let's assess the projectional area. So the patella is sitting laterally, it should be in between the medial and lateral femoral condyles. So if it's sitting laterally, we need to internally rotate the leg to bring it central. The fibula head is almost superimposed entirely on the tibia. So once again, by internally rotating that leg, it will bring this out of superimposition. We should have a clear joint space visualized, so we can see it on the lateral aspect, but we don't really see it on the medial aspect. But this is most likely due to this patient's osteoarthritic changes here, and that's probably why we don't see a nice clear joint space in this medial aspect. And we also know that we should have an anatomical marker present, which it is not. So then how do we improve this image? So if we look at our previous slide and compare it to this one, so our centering point has been drawn out and it's came more medial, and I've moved to proximal, which is what we should be doing. We should be repeating the previous image. We should be improving our centering point, but at the same time decreasing collimation. So increasing collimation will kind of limit the radiation center ray. If we decrease it, we're kind of opening up the area. So that will hopefully help with the area and the centering point as a result. In terms of our projection then, how do we improve it? As we said previously, we're going to internally rotate the leg, so that will bring this patella more central over the femoral condyles, and it will also help to bring this fibular head laterally as well, as it's almost superimposed completely on the tibia. And then we're going to add our anatomical marker on our repeat as well. So I've demonstrated another image here for us to critique. So this one here is actually a lot better in terms of the area and the centering point. It's maybe a wee bit tight in terms of has it included the distal aspect of the femur and the proximal aspect of the tib and fib, but it's not too bad. Our patella is nearly completely in the middle of the femoral condyles. However, we could improve it slightly by once again internally rotating that leg to be midway between the lateral and medial femoral condyles. The clear joint space, is it visualized? Not completely. I suspect this patient has not fully extended their knee, and if they did, I would expect to get a lot better of a joint space visualized there as well. The femoral condyles do not appear completely symmetrical, and that's once again linked to the fact that the patella is not centralized between them. So we can see that this medial one appears to be more elongated than the lateral one. So that's us done. Thank you very much for watching, and I really hope that you found that very beneficial to understand how to undertake AP knee imaging and to be able to critique it appropriately. Thank you.